let's get rolling here. What we're looking at is Medicare Part C. Okay, I'm sure we've all seen this slide before on the 4 parts of Medicare, but today we're going to be really concentrating on understanding Part C of Medicare. And for whatever reason, it does not seem to be going along here, but it is. Okay. So one of the things about Medicare that can be frustrating is that there are so many different names for different things. Okay. So Part C is another name for Medicare Advantage. Now, Medicare Advantage's plans are going to be administered by private insurance companies contracted with Medicare. Part C, or Medicare Advantage, or you may also hear it referred to as an MA or MAPD, covers everything that original Medicare, not your Part A and Part B cover, and may cover some additional or extra benefits. My slide does not seem to want to advance like it's supposed to here. There we go. Now, Medicare Advantage plans, or MA plans, are health plan options approved by Medicare, but they're run by private companies. So like I said, sometimes they're referred to as Part C. Now, MA plans are offered in many areas of the country, and these private insurances actually sign a contract with Medicare, and Medicare pays these private insurance companies for their members' expected health care. MA plans benefits to the members through the plan. It may offer extra benefits that original Medicare doesn't cover. Typically what you're going to see there is like vision and dental, or maybe an allowance for over-the-counter drugs, something like that. And the plan may have special rules that its member has to follow. So to be eligible to enroll in a Medicare Advantage plan, a Medicare beneficiary must be entitled to Part A and enrolled in Part B. They must live in the Medicare Advantage plan service area. And the beneficiary generally must continue to pay their plan premium. Okay. Now, Medicare Advantage plan will help cover the cost of things like deductibles, copays, co-insurance, Part B drugs, and if it's an MAPD, it'll have the drug coverage included. They'll do the preventive services. Among the more popular that will be contained in there will be like a dental and vision. Okay, it'll do that. Yeah, so you get all the services covered by Part A and Part B through the plan, and some will offer additional benefits. Now, some of the more unscrupulous agents out there, so usually they're not AHCP certified, so they're not selling Advantage plans, will tell people that they're giving up their Medicare when they sign up for Medicare Advantage. Not true. You're changing who pays for the Medicare. The individual still has Medicare. They still have Part A and Part B. Instead of the federal government paying, the insurance company pays. So they have to provide everything that was included in Part A and Part B. And sometimes, if it's an MAPD, it'll include those that are covered under Part D. In some plans, like HMOs, you may only be able to see certain doctors or go to certain hospitals, but you're going to save the most money in out-of-pocket expenses when you get your services through the plan's network. So benefits and cost sharing in an MA plan can differ than original Medicare. If a client joins the Medicare Advantage plan, again, they still have Medicare. They'll get their Part A and Part B coverage from the Advantage plan and not original Medicare. A Medicare Advantage Part C was introduced with the specific purpose of driving down cost as it provides more options for consumers. These plans are managed and administered by private insurance companies, but they also still operate under Medicare, and they must be approved before being made available to the public. So Medicare Advantage plans must include all the same benefits as original Medicare, and any basic service available under Part A and Part B must be included in your Medicare Advantage plan offered by the private insurance company. So clients can purchase Medicare Advantage during open enrollment or special enrollments, and they can enroll, switch, or change their plan only during special times of the year. So Medicare Part C is one of the better plans to go with if you're in need of health care and want to be more affordable. Still government-sponsored plan options that provide more than what Medicare offers. And the variety of plans that qualify as Medicare, there's a variety of plans that qualify as Medicare Advantage plans, but you need to understand how these plans work in order to get the best for your client's healthcare needs and budget. Medicare Advantage is different from original Medicare, but it still provides those same services and facilities and doctors that they would receive if they had traditional Medicare. The different types of plans for Medicare Advantage, HMO is probably still the most popular, but there are PPOs, private fee-for-service, special needs. We'll be taking a little bit closer look at these. So Part C is going to help, cover these things. Okay. Medicare Advantage combines Part A and Part B and may even include prescription drug coverage. And it can include additional benefits like eye care, hearing, wellness, nurse hotline. I mean, there's a whole lot of them out there that can be included. Okay, now this is kind of let's see, I'm going to back this up a bit here. I think I got a little ahead of myself. Oh, that's right. Okay, so there we go. Okay. So we're going to look at real quick here, though, is some of the things that Medicare doesn't cover. And this is why original Medicare is not enough. So folks who reach Medicare eligibility review what additional coverage and depend on us agents and brokers in helping them make the appropriate choices. Because there's still long-term care, custodial care, routine dental care, dentures, routine eye exams and glasses, routine foot care, cosmetic surgery, acupuncture, hearing aids, right? Not all covered with Part A, and it would help your clients pay for the cost of hospital if they're sick, but there's some things that it won't pay for, like most doctor services they receive in the hospital are going to be covered by Part B, and they would have to pay the Part B deductible and the 20% coinsurance. So that would be original Medicare. Now, Part A isn't going to cover hospital costs if your charges are itemized on there, and it includes a charge for television or a telephone. Okay, Part A isn't going to cover that. Okay, and it also doesn't help with custodial care, and that's going to be care that helps with daily activities of life like eating, bathing, dressing. Custodial care doesn't require the kind of skilled medical care provided in a hospital or skilled nursing facility. So Medicare Part A does not cover it. Now, we have all seen Joe Namath out there, and providing that list of extra benefits. So the point that I'm trying to make here, I guess, is that we've all seen Joe Namath rattle off a list similar to this, but also your clients have. So this list is not all inclusive or a requirement, okay? In all the various Medicare plans that are out there, I have seen these added benefits. Not all of them on one, but I mean, that's a pretty good list there. I mean, I've seen dental that ranges from a couple $100 where you would pay it and then claim it back to $3,000 in a PPO coverage. I've seen vision that covers various allowances for glasses and the exam. Hearing aids, I've seen that everything from a discount plan to an actual co-payment. Okay. Over-the-counter drugs, typically that's going to be a quarterly allowance that they can use, and there's a catalog that they would order from. Now, meals are generally only provided after surgery. I mean, I don't know of any plan that just provides all your meals, but they do provide those after surgery meals for up to 2 weeks. Some plans even will give you transportation to and from the doctor. They may limit it to 3 or 4 round trips a year, or there's even some that it's unlimited. Debit cards, I have seen, and some of the plans are experimenting with this, where they'll actually issue a debit card to the customer, and it's going to be good for those over-the-counter drug items, right? Because when I say over-the-counter drugs, it can also include things like adult diapers, Band-Aids, personal hygiene equipment. It's more than just aspirin and cough syrup. Medical alert systems. It may not be the the one that you see advertised on television. Hey, I've fallen and I can't get up. That particular one, but there's literally dozens of companies out there that provide that medical alert. It's usually either hooked to your cell phone or to your plan. So you can be able to get it that way. Gym memberships. It can vary from silver sneakers to an allowance for gyms. Depends on the companies. Active, I think, is the United Healthcare's these days. And I've seen where they'll do Part B rebates. What they'll do is actually send back to the individuals that part that is charged out of their Part B premium. In other words, literally, when somebody gets in a Medicare Advantage plan, Medicare pays roughly $1,000 a month for each member in the plan, to that company. And so of that, a part of the money they're collecting, or Medicare is collecting that Part B premium. Some of the companies actually rebate a portion of that. This is one that comes up from time to time, and it deals with having a special election. And the one that I'd like to just really call your attention to here is that I've moved back to the U.S. After living outside of the country. Now that is, you got 2 months after you've returned to the U.S. to sign up for this Medicare drug plan or a Medicare Advantage plan. But here's the thing, you had to have kept your A and B. Many times what happens is because A and B doesn't work outside the country, they drop their A and B while living abroad. And then when they return, they think they can just enroll in this Medicare Advantage plan. For those who have listened to some of my earlier, what is, and I'm just going to, this is a question, if you could just chat me the answer here. What is the only SEP for enrolling in Medicare? Can anybody give me that? Give you all a moment to response. There is literally only one SEP if you have not enrolled in Medicare. Okay, so you're age 65 or greater, you didn't enroll during your your 7 months at the beginning, and now you want to enroll. Okay, well, I'm not seeing any answers here, so I'm just going to have to move on here, and that is perfect. You got it. You had to have actually lost your employer plan. Loss of group coverage is the only SEP for Medicare, not moving back into the US after living abroad, okay? So many people will find themselves stuck in that position where they've moved back to the US. They have to wait till January in order to enroll during open enrollment, January 1st to March 31st, for a plan that won't start, or for Medicare that won't start until July. And that is when they would have been able to enroll when their Part B started there in July to enroll in the Medicare Advantage plan. And the same thing for being released from jail. Now, those people that are off in the prisons, right? They turn 65, and maybe after that, they figure they're just too old to be a problem anymore or whatever, and they get released from jail. If they didn't get signed up for A and B while in jail and prior to that release, they're not going to be able to enroll in a Medicare Advantage plan. They have to enroll in Medicare first. Okay? I don't understand, and this is just one of those that's just a curiosity thing, is that while they were in jail, all their Medicare was being provided, all their medications and health care was provided by the state. But being released from jail is not a loss of health care. So who knows? Anyway, so I would have thought that would have given you the SEP to enroll in Medicare, but it does not. Okay? But all the others will give you an SEP. Okay, so let's look at these different types of Medicare plans that are out there. Probably seen most of these, an HMO, in all the, just like in the under 65 world, HMOs require that you stay inside the network, that you get your doctor or specialist or hospital from the network, and except for emergency care, you're allowed to go outside. Whereas the PPO does give you a little bit more latitude. Your cost will go up if you go outside the network. In fact, you are required to disclose that during the enrollment in a PPO, that you'll pay less if you stay in the network, but you will pay more if you go out of the network. And then there's special needs plans. Now there's two different types, basically, Medicare and Medicaid. That's the dual eligible. And then there's the chronic conditions. Those chronic conditions are everything from COPD, ESRD, heart diabetes. I mean, whatever one is in the area. You mostly see the chronic plans in major metropolitan areas where there's just enough people to make putting together one of those kind of plan networks feasible. There are some not so commonly used plans, and that's this list here. The one that's called the private fee-for-service plan. Now, members can go to any provider that accepts the plan's terms, and they can still get those extra benefits. They'll still include a lot of those things like the dental and stuff in those plans. But the private company decides how much it will pay and how much the member will pay for their service. The key thing, though, is that each visit that you make to the doctor is the doctor has to agree at that time to accept the payment. In other words, it's not a blanket the first time you in. Each visit requires that the doctor accepts the plan and the plan payment. These are pretty big and popular, again, out in the rural areas where there's just not enough to put together an HMO or PPO network. Right? So they'll have the private fee-for-service. It can have a network or not. It doesn't, it's just not critical that it have a network or not have a network. Each time you see the doctor, they have to accept the plan. Now, the medical savings account plans, that's an MSA. Again, think of it as just a high deductible plan so that you would use your savings plan where you accumulated money to pay the high deductible or pay your cost, just like in an HSA for under 65. It's just now it's called an MSA for over 65. So if you had, I've had many clients that have had, thousands of dollars off in their HSA, and now when they're turning 65, so an MSA is a reasonable plan there. And so what they can do then is not only Medicare contribute to your plan, in other words, you're in that plan, they put in a couple $1,000s a year, and that is supposed to cover, when you go in and you do your annual checkup, or you go and you get that flu shot, and all of those things that are covered process, but they're part of your deductible. And then once you met your deductible, you're 100% covered. Okay? So those are great plans for those who have already, have HSAs. I'm not sure that I would want to, with just about $2,000 a year, I'm not sure how much you can get done without, you'd have to really start to, build up some money in there. But there's some out there. Again, those are just not real popular plans. And I don't really understand why the cost plan never caught on. Medicare has eliminated a lot of them. They're still available in Colorado, Minnesota, Texas. You still see them in those places. But think of it as being in an HMO so that you have that network. Only when I go out of the network, whereas in the traditional Medicare Advantage plan, if I go out of network, I bear all the cost. In the cost plan, if you go out of the network, I'm just on original Medicare. So I still have to meet, if I go to a non-network hospital, I'd have to pay my Part A deductible. If I'm using, doctors outside of the network, I'd have to meet my Part B deductible and pay 80%, excuse me. And Medicare would pay 80% and I would be paying, my 20% co-insurance. And inside the network, I would just have my typical HMO type plan. For whatever reason, these never really caught on and are pretty much going away. So you just don't see them much anymore. But I always liked them. I thought they were pretty good plans. Okay, next slide is star ratings. You just have to understand, because these are things that you are going to go over with your customers, is the star rating of the plan. And typically they can be, pretty low down. I've never seen a 1-star, but I've seen some 2s and 5 stars. Remember that they are made from member surveys that they do. Let's see, I got a question here about credible coverage. We'll be talking about that in ad nauseam in a minute, so just kind of hold on for that one. The 5-star plans, it says allows year-round enrollment. I hate to really be technical, but it's all but 1 week of the year. So it's 51 weeks per year. If you read in there, it says that the 5-star enrollment opens up on December 8th and closes on November 30th of the following year. So that leaves you with 1 week where there's actually not a year-round enrollment, but that's just being technical there. If you have a 2-star plan, you can actually, that's an SEP, and you could change your plan. I would never enroll somebody in a 2-star plan. And let me qualify that never, unless that was the only plan available. Okay, but I've seen that come up a lot, and Part D plans, which we'll talk about here in a moment. But they still have, for those plans, a star rating also. Yeah, just that word of caution that goes with there is that if somebody has an HMO or a PPO, the more traditional Medicare Advantage plans, and you try to go and enroll in a separate Part D, it will cancel the previous enrollment. So they would, instead of picking up, well, they would pick up the Part D, but they would lose their other coverage. The only Advantage plan that allows you to pair with a, I say that it's old, but again, it's, there's all these different exceptions in here. It's the private fee-for-service can have a freestanding as well as a cost plan. That needs to be added onto the slide there. Cost plans can have a have that also. So now these are just kind of deciding what you're going to do with that customer and how they're going to do it. So understanding how that Medicare Advantage plan you're considering, is going to work with any other coverage they may have. And here's the big caution: if they're in a retiree plan or some kind of employer health coverage, they could lose that when they enroll in a Medicare Advantage plan. And the big reason behind that is most of those plans, the retiree plans or the union plans that are out there, are relying on Part A and Part B of Medicare to be paying, that 80%. So that even though they say that they're providing the health insurance, they're really only doing 20%, right? So that's how they're controlling their cost, is they have that requirement that you're in A and B. So when you sign up for Medicare Advantage, remember you're switching from the government paying A and B to that Advantage plan paying the A and B. So the union or the retiree plan loses that money. So once you've done that, many of them will not let you back in again. Okay. So you do want to compare the coverage and cost available through traditional Medicare, maybe combined with a Medigap policy and prescription drug plan versus the MA plan. I've seen many times where that patient or that customer had so many different doctors, it was not possible to be affordable in a Medicare Advantage plan. So inquire with the Medicare Advantage plans as to whether and what extent, they're providers. Do they have big, wide networks, or are they more narrow networks? You're going to actually have to look up every physician that is used by your customer and verify that they're available in the plan, or let them know that they're not. Okay, so that that you can know if it's in network or out of network. It's one of the requirements during enrollment. And you want to review, the plan's literature to see what kind of plan it is and what it pays for. Not all Medicare Advantage plans, even if the plan is the same type, HMO, PPO, from the same insurer, you'll see in some areas that company will have multiple HMOs and multiple PPOs, but they don't work the same way. So the caution there is they may not have the same doctors, they may not have the same benefits, co-pays. You just have to go through it all with them. Then if we're enrolling in a Medicare Advantage, what about prescription drugs? Okay, we need to look up each and every one of those drugs. And typically, this is one of the major reasons there are multiple plans in the in a network, in an area, multiple HMOs, multiple PPOs, is that they're using different formularies for their Part D. So it may be more advisable to pay more for the plan to have a specific drug covered at a reasonable cost. Okay, we'll see more of that under just Part D also. And you want to determine, what's being provided at what additional cost. Is it included in the plan, or is it an optional supplemental benefit that has to be purchased? A lot of times that was the dental. It was not part of the plan. It was a supplemental benefit that could be added to the plan. So we do have to kind of look out for that, because I've seen that in more than one plan. Let's see, next slide. So like I was saying, when it comes to like Part D, we just want to look up the drugs, make sure it's in the formulary, look up the physicians, make sure that they understand, what does it cost and what is the limitations for emergency, urgent care, in network, out of network, when's it covered. Even the HMO is going to cover stuff out of network. Okay. It just has to be a certain condition. Emergency care, HMOs will cover it wherever you are, where that nearest doctor and hospital is. Okay. That HMO may cover an out-of-network doctor if that HMO doesn't have any of that specialty nearby, or within a reasonable distance, and you get a referral, and that's the only doctor that's available is out of the network, well, then they'll pay for it. So you just have to kind of make sure that your customer understands that. We can't really talk about HMO and PPO plans and Medicare Advantage without at least touching on hospital indemnity plans, because they pair together just so well. One of the features of a Medicare Advantage plan is that they're required to provide an a max out-of-pocket maximum. Well, what if your customer doesn't have the funds set aside to cover those larger co-pays? Maybe that $1,000 deductible, or that $450 a day for hospitalization, or the $250 for the outpatient surgery that they need. Okay, I've had customers that just had a monthly debt that they simply continued to just pay to the hospital. They just couldn't get past it. Every year it just got added to, and they just had that continuous monthly payment. So I believe that we owe it to our customers to show them how to get protection for some or all of those out-of-pocket expenses. This is kind of a picture of that typical zero-cost Medicare Advantage plan. I looked at, this is one that's in my area from Aetna. It is a fabulous plan. I mean, it's really enriched with all kinds of stuff for classes and dental work, and co-pays for getting things like a radiology. And I mean, just but the problem that it has is for all the major stuff, there's that $1,000 deductible. But this one's pretty typical. Okay, I mean, if you look at these zero advantage plans that are out there, may or may not have a deductible. Typically, you'll see that most often with the PPO plan. But a hospital stay, about $300 a day for the days 1 through 4. If you get held for observation, you'll pay 20% of the cost. I've seen the outpatient surgeries, from $150 to $300. Yeah, not too much concerned about a primary care physician. Most of them are zero, especially on, that's one of the features of the zero cost plans is zero cost for your primary. But I've seen them, cost up to 25. You don't get a free ambulance ride with it. It's still looking at probably around the 250 area. Emergency room, typical 90 to 100 bucks. Urgent care, 35 to 50. Medicare covers that skilled nursing facility for days 1 through 20 with zero copay. And so they're all counting on that, but they're going to make the individual pay that $178 a day. They'll pick up the rest of the bill inside the skilled nursing facility, but the $178 a day will go to your customer. And the more expensive stuff when it comes to diagnostic radiology or even radiology treatment or chemotherapy plan on 20% of the cost. Although I've seen many of them break out MRI and CT scan with a payment of like $250. So that's pretty decent. So that's that zero cost plan. And it has that, max out of pocket could be as high as, $6,700. But typically on this plan, you're probably looking at about a $4,000 max out of pocket. You still want to be able to protect for that. This is just a screen print from SureBridge. One of the features that it has that I just wanted to point out is that when you go to their plan builder, you just simply select the year, what the plan what carrier and what that plan is, and it'll show you where the holes are. Okay, that's the only feature that I think is really cool on there. So I had no problem before just going through the summary of benefits and pulling it out there, but they have a neat little feature that pulls it out, and then where they recommend that you put what values that you use. So here's the screen, right? I would review this with my customer. Okay. What you would do is, put in, how to cover, my $300 a day for days 1 through 6, cover the ambulance ride, cover the emergency room. There's that $1,000 if because that's typically where it comes into play on at least the plan that I was looking at there, that Aetna Elite. Only came into play for certain things, and it was going to be the hospitalization and outpatient surgery. Other than that, it was the only things that applied the deductible to. So this is a way that you could cover a lot of that. Okay? And also you see that you're looking at a premium of about 80 bucks. Okay? So I went over to Aetna. Aetna also has that daily hospital indemnity that you can use for your customer. Again, I would just simply review this with my customer. How much of a benefit do you need? Okay. Again, $300 a day for the 4 days, ambulance. One of the features of Aetna is a cancer lump sum, selectable from $2,500 to $10,000. Kind of neat one there. Of course, that'll really change the premium. But I was just trying to show that. Or maybe the customer simply says, I only need to be able to cover that deductible. Okay. So I use the hospital admission indemnity. It pays out $1,000 if you're hospitalized. Okay? And that also would include observation. So that works out pretty well. And now you're just looking at a $40 a month. I'm just trying to give you some ideas, and just think that we owe it to our customer to show them how to cover those costs that are there. The lead for selling this product starts when you're doing the CMS required disclosure on the summary of benefits for that MA or MAPD. The first one that comes up in the summary is going to be a deductible if they have one. The next one is going to be the per day for hospitalization. And so just that simple statement, so Mr. Smith, do you want to be able to make that payment? Or would you like someone else to make it for you? Almost every time that answer is going to be, I would like somebody else to make it. And so that's just the lean in to show them how that can be covered. Okay. So that was, part C and a little bit on hospital indemnity and how they pair together. I just think they're the natural pair, especially with a lot of those zero cost plans that do contain a lot of liability and risk. So now we'll take a look at part D. Okay, here we are, 4 parts. Part D, remember that's going to be, it can be a freestanding plan, or it can be part of a Medicare Advantage plan. Okay, so in the MAPD, we get A and B together with Part D, and in the freestanding, we're getting prescription coverage only, and there won't be any medical in there. Now, Medicare Part D plans are, when we talk just Part D now, are freestanding plans that are sold by private insurance company. They're all different, yet they do follow the basic Medicare Part B beneficiaries with income above certain level will have that increased payment. Don't forget about that IRMA, month income related monthly adjustment amount. That's going to apply to your Part D. And they're going to charge you a monthly fee so that in addition to your Part B premium, which is one of those things that you're going to have to be sure that you tell them that they did not get away from their Part D premium. Individuals with income of less than about $1,800 a year, $18,000 a year, or couples with less than $24,000 a year, probably are going to qualify for extra help. We'll talk about that in a minute. And individuals on Medicaid or in a skilled nursing facility, or if they're receiving SSI, they're going to get extra help just automatically. And other individuals are need to apply, and like I said, we'll talk on that some more. So here's kind of that basic, formulary. Now, Medicare has a list of drugs that they authorize. Not every company is required to cover everything that Medicare covers. They are simply required to have 2 drugs in every therapeutic category. Okay? So that can be a combination of generic and name brand drugs. So now that does not mean that they're all going to be affordable. Okay, on that really cheap plan, that formulary may list that 2 of every category, but that doesn't mean that they're all going to be tier 1 or tier 2. It could be tier 4 or tier 5. Okay, so they just have to have 2 drugs for every therapeutic category. Premiums, premiums, those are also different from plan to plan. That plan that covers, with a very rich formulary that's going to cover multiple prescriptions, for drugs in multiple categories, and go beyond that with 2 that are required, can simply and make it down there in a tier 2 or tier 3 of the plan. Can make those drugs a lot more affordable. And so there's part of those premiums, and also don't forget that what's going to get added to the premium is the IRMA. Deductibles, okay? There is a deductible. It changes every year. This year it's $435. I haven't seen what it's going to go to in 2021 yet. Co-pays for the tiers. Now the tier system is out there. I think I have seen everything from 4 tiers to 6 tiers in the various plans. So tier 1 is always going to be that generic. Tier 2 in the typical plan is the 5 tiers. So tier 1 was generic, tier 2 was preferred generic, tier 3 was preferred name brand, tier 4 non-preferred, and tier 5 is specialty drugs. Okay, and each, depending on that tier, will have a copay or co-insurance that goes with it. The maximum that they are allowed to charge is 25% of the cost of the drug. Okay. Then keep in mind pharmacies. There's that preferred pharmacies where things will always be cheaper versus the standard. So and those usually go, surprisingly, Aetna, CVS is always going to be the preferred pharmacy. There could be others, but I remember that Aetna owns CVS or CVS owns Aetna. I never get that quite straight, but that's always their preferred. I think Walmart is probably in everybody's preferred network. You always see United Healthcare doing like a lot of Walgreens, right? That's part of their plan. Anyway, those are their preferred, but you can still go to another pharmacy that would be standard. You'd probably pay a little bit more in standard. And then you can go with mail order. You're also required to, when you look up that prescription for the customer, to tell them what the tier is and what the payment is. You have to disclose any of the cost utilization methods. Okay, so and the big ones that come up are usually the ones that will get the most complaints. Will be step therapy. Okay, so if it says ST can mean that they're going to be required to attempt a less expensive drug prior to doing the one that was called out by the doctor. And they'll coordinate with the doctor when they do that, but they will have that step therapy requiring them to try something cheaper first. Prior authorization, one of my favorites. I always emphasize that if it's a prior authorization drug, don't take that last pill and then go to the pharmacy, because it could be up to 48 hours for to get your authorization. And that's all staying legal. Now, typically, they can do it, on the fly right there at the pharmacy. But the moment you count on that, you'll be that 2-day one and be forced to go without meds for 2 days. And quantity limits can be done with a very expensive drug, or it can be always seen on any kind of narcotic or abused drug, so that they'll limit that down. Usually you'll see 30 days, but I've seen, 1 week on some of the narcotics. And then we'll see what happens in the donut hole business too. Now here's the current, this is 2020, a $435 deductible. That's going to take you up to $40.20. Okay. Now they're tracking the true cost of the drug. Okay, so we're going to take a minute and talk about that. That is what the true cost that the plan spent on the drug. That's what's being monitored. If you buy something that's outside of your plan, and here's what I've seen happen a lot of times is back here in the initial deductible, you want to go buy something and you have to meet your deductible. And I can go grab my good RX and pay a whole lot less than what that standard price is. But I bought it outside my plan, so I never met my deductible, nor did it go into my true out-of-pocket, because the assumption made, or the requirement is, that you purchase all your prescriptions through the plan. Anything done outside the plan, as far as they're concerned, never happened. You bought it cheaper through the Canadian pharmacy that you were using. Okay, did not get included in your true out-of-pocket. And what it'll do is it'll change where it'll affect reaching your deductible. It'll affect the coverage limit, and it'll affect getting to your out-of-pocket threshold. Okay? So the way things will work here is from you'll meet your deductible, if there is one, then you'll pay whatever that copay is for the drug. It could have been $1,000 drug, but your copay was $35. Okay, so with that you would rapidly reach your 4 months into the year, you would reach your initial coverage limit, and you'd be in the coverage gap where you're paying 25%. Okay, now under that initial coverage limit, they cannot charge you more than 25% as part. So you could have a copayment in there of 25%. Your coinsurance on that really inexpensive prescription drug plan. I think Aetna's going to have one out next year that's going to be about $8, for the Part D. Be great for that person who takes nothing, but is not going to be a one for somebody taking, a lot of medications, because they can charge that 25% copayment during the initial coverage. Okay? Until that out-of-pocket reaches that $6,350, then you go into your catastrophic coverage, which you'll have to review all of this with your customer. Yeah, there's a lot of little things that go with that. That to understand that that minimum cost sharing is the greater of 5% or $3.60. So if it's a generic and it costs more than $3.60 when it's 5%, you'd pay that. Okay, so just keep that in mind. If it was $100 generic, say it was an EpiPen. I don't know if you can get one for $100. I think even the generic's more than that, but just for sake of argument, we'd say that it's they're going to charge you the 5% now, so you're going to pay $5, not the $3.60. And if it was something that's name brand, you're $5 or $8.95, whichever is greater. And then these payments down here apply for those who are getting some sort of subsidy. Okay, they would never pay more. The 5% goes away. Here's an easy way of looking at this. Okay, look at it as 4 phases. In this model, this is what all plans are measured against. Remember, there is not a government plan. There's not a government Part D. The government, through CMS, provides this model that all plans are measured against. If the plan meets or exceeds this model, that's considered to be credible coverage. If the plan does not meet the requirements of this model, it's going to be deemed non-credible coverage. And they have to notify all the participants who will now have an SEP to enroll in coverage. So you're in that plan from work, or you're in that plan that was when they retired and they were a union member, and that plan included prescription drug coverage. They should every year get a letter that says you have credible coverage. Okay? The moment that letter says it's not credible coverage, they're going to have to let you enroll in a standalone prescription drug plan. Okay? So here's kind of the way that it goes. During phase 1, that's that deductible phase. Whatever it is, the maximum they're allowed to charge is $4.35. It can be less. Okay? It can even be 0. So if it's 0, you're just going to be, you're immediately into phase 2. But otherwise, you have to meet your deductible. Then in phase 2, you're going to have a copayment or a percentage, okay, a coinsurance of the cost. It cannot exceed 25% of the cost of the drug. Okay? So that's why they say that there's really no donut hole anymore. But that's just for argument, because they could have in phase 2 charged you 25%. Most companies have a copay. Okay? But there are those that are still using co-insurance. Anyway, when that true out-of-pocket reaches 40/20, you're now in phase 3, in which the cost is 25%. Now, not every Part D plan out there uses that. They could have special coverage inside that area in the coverage gap, okay? So that you're still doing some kind of a copayment. So this is just simply the model. Anybody can be better than the model. They cannot be less than the model. And then phase 4, you're into catastrophic coverage. And so we'll talk some more on that part. So extra help, okay? So one of the things that I get a lot is how does someone escape the donut hole? Or what if I still can't afford my drugs? Well, to be honest, there's not much, but LIS is the closest thing. And a lot of people already qualify, but they don't even know it. So it's a financial assistance program that helps qualified Medicare beneficiaries pay their premiums, their annual deduction, and their prescription cost, okay, the copays and the coinsurance. It's great for the beneficiary if they qualify because based on their level, they get reductions in the premium. And it's great for you as it creates an SEP, which means that you could enroll that person in a Part C or a Part D plan outside of AEP. So basically, it kind of goes like this. If you have an income and resources, and there's a formula that's less than about, 18,000, they're going to qualify in there. And I have done many application for customers. It's done on Social Security's website. You're allowed to do that for your customer. You're going to usually have the customer with you or on the phone with you because they're going to have to give you some information like their Social Security number and stuff like that, and their income and all those factors that you're going to need. And then you're going to put on there that you're doing it, because it's going to ask, is somebody helping you with this? And yes, so I fill in my part, and you simply are going to help them and submit it. One of the things is that it takes, forever, 6-8 weeks for them to get a letter back. However, if you are really working with the coverage, and let's see, yes, Social Security does count as income. Okay? Keep in mind that over half the country's Social Security is less than this already, okay? And they're living on it. I mean, for half the country, I think the average check out there is like $1,200 a month. Not much. Anyway, so you help them get through that. You can log in to their Medicare, Medicare.gov with them and see if it's been approved or not. It'll show up long before the letter comes in the mail. Okay? So this is going to help them pay that monthly premium, and it's usually by the where you live. I mean, on the low end, it's $20-some a month, and on the high end, it's about $40 a month. Typically, it's around 32. Anyway, it'll based on your zip code and stuff. So you get the monthly premium. Your deductible goes to 0, and your prescription co-insurance payments really drop down. If you were late and had that penalty for late enrollment, it goes away, and you also have coverage in the gap. Okay, so this is kind of different places where you'll see it. If they're full benefit, dual eligible, institutionalized, they'll pay 0 for the drugs. If they're just not institutionalized, but they're making less than 100% of federal poverty level. Here's the big thing, and you see this with people that came off of Medicaid and stuff like that. is, you remember when they were on Medicaid under 65, they didn't pay for drugs. So now they've turned 65 and they're still on Medicaid, and suddenly they find that they do have to pay. Now they don't pay much. You see here, it's going to be like $1.25 for generic and preferred drugs. And if it falls under those, tiers 3 and 4, it can be $3.70. Now that's a slam for those people who have never paid, okay, and now suddenly do have to pay. So until they reach that true out-of-pocket that puts them above the that troop, then it's zero. Then they won't pay anything again. But a lot of those find that it's a shock, especially for those that are coming in off Medicaid. For those who are just on Social Security, and that's their only source of income, they'd probably qualify, because it goes up to 150% of poverty level. So if you're greater than 50%, you've still got a zero deductible. And now these are the maximum cost. If you were taking something that costs less than $3.65, you'll pay less. However, that's the maximum you can be charged for that tier 1, 2, and 3. And tier 4 and 5 can still go up to $8.95. But once you reach that catastrophic limit, your costs go to zero. And maybe you didn't qualify for the full extra help. Okay, you only got some of it. Okay, so now it reduced your the deductible. This is worst case. Okay, that you qualified, but you got only maybe 75%. That's what they rated you at. That's kind of the worst case scenario for extra help. Still reduces your deductible down to $80.30 would be the deductible. And instead of 25%, you're down to 15%. And once you reach the catastrophic limit, the 5% goes away, and there are flat co-payments of $3.35 for tiers 1 through 3, and $8.35 for tiers 4 and 5. One of the things that you just still have to remember is even though all these costs went way down, if the drug's not in the formulary, nothing helps you, okay? It still has to be in the formulary. Now, they can get a formulary, or they they can apply for a formulary exception, but that does not mean that they'll get it. Okay? So usually that's one of the things that you would tell them is that that's not covered. And usually where that comes into play is during the year when you're doing your checkup with people, because I always called my customers quarterly, and you find out that the particular new prescription they got is not in the formulary, or maybe they called you saying, hey, I've got some problem here. I went to the doctor, he wrote me this prescription, and they're saying that it's not in my formulary. Okay, so you can do the formulary exception and try to bring it in that way. If they do bring it in, it'll be a tier 4 or tier 5. But for those that are on LIS, okay, I can still, get it down to $8.35. So we need to talk about IRMA. That's that income-related monthly adjustment amount. That comes up, and usually here's where it comes in, is that somehow after you've enrolled them, they found out that they're being charged more than the premium that you told them. One of the things that you'll do during the enrollment is you'll talk about this. You'll tell them, and it's a statement that you read to them, but most people blow it off, okay? And I'm not talking about those that, because we all do it because we know we're required to cover that, but they don't really fully get it. They don't ask questions about it, and it just goes over their head. But when you get that phone call back where they're saying, what is this? I'm being charged this extra fee on here. You told me it was going to be, $30, and I'm paying over $45. Okay, so that's because the IRMA kicked in. And it's because IRMA is based on not what you make today, it's what you made 2 years ago. And in the cases that I've had it, I have found that what happened was one of two things. One was they took a severance, and so that 2 years ago, when they took the severance and it went onto their income tax, it showed this huge amount of money. And on the other one was somebody had sold some property, and it wasn't their primary residence, and so they had this extra money on there that they had paid taxes on that made it look like 2 years ago that they made all this money. So anyway, here's the table. So you can see that for most people, as long as you make $170,000 or less as a joint, or as an individual, 85,000, you're just going to pay whatever the premium is. But once you get above either the 85,000 or the 170,000 for the joint return, it kicks in more money until you reach that max down there. Joint return of $750,000. I don't know why they'd be complaining about $76 a month, but they would be. Anyway, that's where it came from. Okay, and it will go away through time because by the time they're starting to look at, in 2022, when they're looking at your 2020 income, it will not show that in the IRMA will go away. So here's your enrollment periods for Part D. The initial, you can probably beat that one to death. That's right there with Medicare. You get your annual, and during that is when you can join, switch, or drop. Now remember that it's the last time that you put the plan in. Whoever is, if they've talked to multiple agents and they've done multiple enrollments, because the last one they talked to made it sound better than the other one. Anyway, whatever, that last plan that goes in is going to be the one that goes into effect. Now, I want to caution you because sometimes there's agents out there that think, hey, what if I just sort of hold on to that application and I don't submit it until the 7th? I'll be the last one. Well, that's illegal. Remember how much time you had to get that plan in? It was 24 hours after you took the application. If you held on to it and submitted it like that, they'll probably still get that plan, but you won't get the commission and you'll get in trouble. So just be careful. Just know that that last plan is the one that happens. So if you got that flaky customer, make sure that you're just doing it with them on the 6th or 7th of December. Okay. And there'll always be a January 1 effective date. Okay. Special elections, like I said, we saw a lot of those, and we'll really beat that to death come September 7th. December 7th, when after open enrollment is over, we'll have a special webinar on SEPs. There's a booklet that you can go out and get, and I always recommend that you do. From United Healthcare, if you're have an assignment with them, that will give you a real breakdown of all the SEPs. It's about a 60-page document, but it was one of those that can't sleep. Maybe I'd like to do a little reading to help. There's a good one. Okay, so you got your late enrollment penalty. The official penalty will be calculated by CMS. So here's all the little rules. Okay, it's 1% of the national average. It's actually been going down because the cost of plans have been going down. But it's going to remain in effect as long as the enrollee has a Medicare Part D plan, if they didn't enroll when they first were eligible. Okay, so that's where we get into that credible coverage. As long as you have credible coverage, then there is not a penalty. And I've got a slide coming up that I'll go over a little bit more over exactly what credible coverage is. So now here's the way the penalty is calculated. Okay, it's about the average is $32.74 this year. So it's going to be about 32 cents a month times the number of months. Okay, so you can give them a ballpark. Okay, when somebody wants to know, what's my penalty going to be? Instead of saying, well, it's 0.3274 for every month that you didn't have, you can simply take 32 times the number of months. So if it's 2 years, so we'll do a quick calculation. 24 months, there'd be an additional $7.68, added to their plan for the rest of the time they have a Part D plan. I did have a customer one time that was in her 80s, never had a Part D plan, and had moved to an area that the only Medicare Advantage plans available included Part D. And so she wasn't able to get an MA only plan in that area, and well beyond the time that she could afford a Medicare supplement. So you were looking at not, almost 20 years worth of, so that was 240 months times the 32 cents. So you're actually adding another $76 to the cost of that plan. Okay. So yeah, this can become a significant penalty for those who wait too long. Okay, so here's some, the credible coverage. We'll talk about that. So if you have coverage from like your current or your former employer or union, you'll get a letter each year stating whether or not the coverage you have is still credible. Remember, that's going to be compared against that model that we saw a few slides back. Does that plan that you're in, have a minimum of 2 drugs for every therapeutic category? That's one of the criteria. Is your cost, your deductible less than $435, et cetera? All of those features in there, you had to be as good as or better to be credible. So some of the ones that are credible, like I said, is current and former plans. They're going to send you the letter that says it's credible. The moment you get one that says it isn't, you got 60 days for an SEP. Retired military people who are in TRICARE, they have credible coverage. Native Americans using the Indian Health Service, okay, on or off the reservation, they can still have credible coverage. Although a lot of the ones that I've dealt with, it just avoided the penalty. They were able to just get an MAPD, and a lot of times the costs were pretty insignificant. And if they did need something expensive, they would simply go back and get it through the Indian Health Service. And I've seen the same thing with people that use the VA. A lot of the VA members, one of their favorites is to get that MA only plan because it picks up so many other things that they want. And even though they can get their hospitalization and things like that at the VA for either a pretty low cost or no cost at all, just kind of depends. Very few actually get vision and dental. So they want those other benefits that are attached to those MA only plans, and those are getting richer and richer in benefits, and more of these people, just simply, why not? It's a zero cost plan, and I'm still getting my drugs, and I'm still getting any major medical at the VA. Okay? Or if you have an MA plan, that's going to be credible coverage. And there's other health coverage out there. And I always get it, well, what others? Didn't you hit it all? Well, there's things like those few that are still in Plan J, right? Remember Plan J on an MAP of the old grandfathered Medigap plans did provide coverage. There's an example of another individual health insurance. So there's still some things out there that still provide that. And that's it here for today.